Hi, everyone. Thank you so much for joining us tonight. We're going to get started. So today we are going to be talking about the indications for physical therapy and the benefits of gross motor play. So this presentation was created and is being presented by myself, Caitlin Kennedy.
And me, Caitlin Chambers.
So we're just going to start by introducing ourselves. So again, I'm Caitlin Kennedy. I graduated with my doctorate in physical therapy in 2023 from Creighton University. And through my clinical experience, I have treated patients through a pediatric outpatient setting and in the hospital setting as well. I also have previous experience working with children with autism through inclusion counseling and respite care. And then I started here at CSTA in June of 2023. And just one of my favorite parts about working with the clients here at CSTA is seeing how proud they are when they achieve a new skill and just being able to help them learn new skills and find new independence.
And I'm Caitlin Chambers. I graduated with a doctorate of physical therapy and have been practicing since 2021 with experience in the outpatient adult and outpatient pediatric setting. Being a physical therapist at CST Academy has been such a fun and rewarding experience, and I'm looking forward to continue growing and working with our clients, advocating for and educating our clinicians and families on the benefits of physical therapy is something that I'm passionate about, and I have loved collaborating with our BCBAs and OTs and SLPs. In my sessions, I strive to provide a safe and supportive environment for our learners that encourages fun, all while working on their goals. So first, we wanted to address why it's important to practice and explore different gross motor skills. Gross motor skills support a child's ability to perform activities of daily living, like getting dressed, safely navigating their environment, and maintaining and building physical strength. Evidence has supported that gross motor skills and social skills are interrelated. Effective social interaction requires individuals to perceive their social partners' verbal and nonverbal cues and use this to guide and adapt motor behavior and communication. Examples of these interactions include mirroring body posture, nodding along with a partner to express recognition, and pausing in response to facial expressions. Learning and practicing gross motor skills with a physical therapist in an engaging and supportive environment can enable children to feel confident and secure enough to participate in physical activities like sports and playground games with peers and family. Promoting global core and upper extremity strength provides the stability, body awareness, and proprioception needed for writing, cutting, and dexterity. And lastly, achieving developmental milestones and promoting optimal movement patterns is critical for future musculoskeletal health. Assumed postures and movement abnormalities like W-sitting, toe walking, and deficits in gross motor skills can lead to limited mobility in joints and muscles, as well as pain later on.
So then just some general indications for physical therapy in the pediatric population. So one thing to look for is range of motion. If they have decreased spinal mobility, if they have decreased scapular and glenohumeral mobility, so just decreased shoulder mobility, that can affect their ability to perform ADLs and engage in types of fine motor and gross motor play. Decreased ankle mobility can affect toe walking and just their ability to reach age-appropriate milestones and gross motor skills. And then also we'll talk a little bit about some strength, coordination, and balance indications a little bit later on.
We'll discuss what does a typical PT session at CST Academy look like. It'll include the integration of vestibular and sensory regulation techniques in collaboration with the client's occupational therapist. We work on addressing functional gross motor skills such as stair negotiation, balance, jumping, climbing, and fall skills. We'll address specific range of motion limitations and strength imbalances. We provide opportunities for our clients to build confidence while working on coordination and motor planning skills. And most importantly, We focus on having lots of fun with our clients. Large open spaces such as our gym and gross motor play can be overwhelming and dysregulating for the body, and we prioritize regulation and collaborate with our clients' OTs to make sure that we are effectively implementing regulation strategies for our clients. Sensory motor integration is essential for coordinating movement, maintaining balance, and effectively interacting with the environment, and it involves the visual, vestibular, and proprioceptive systems. Children with sensory motor integration challenges may have difficulties processing sensory input, leading to uncoordinated movements and struggles with everyday tasks. Signs of difficulties can include tripping and falling, silliness, avoidance of obstacles or physical activities, poor posture or difficulties maintaining balance, and difficulties participating in multi-step activities.
So now we're just going to get into some more detailed explanations in different categories of things that we as pediatric PTs can treat. So we're going to start off just by talking about posture and positioning. So something that we commonly see, especially in the ASD population, is W sitting. So this is a sign that a child might have decreased core strength and endurance. In the W sitting position, which is that top left picture on this slide, you can see that their base of support is very widened in this position. So they're just trying to give themselves more stability. However, W sitting is a position that can affect hip tightness and limit their hip mobility. So it's something that we'd like to avoid. And so we can work on strengthening their core and increasing their hip mobility in the opposite direction to encourage them into a tailor sitting position, which is the top right photo you see there. So this is preferred just to encourage better hip mobility and core activation in our clients. And then in terms of standing posture, that bottom left photo shows what we're looking for with ears, shoulders, hips, knees, and ankles all in alignment. On the right, you can see the slouching posture where they're not engaging their posterior chain as much. And then in that lordosis, that just means that they have an increased curvature in their spine there. So they're not engaging their abdominals in that posture as much as we would like them to. So again, those are just signs that their core endurance is a limiting factor in their ability to maintain an upright posture.
Transitions also require a good amount of range of motion, coordination, strength, and motor planning, and are important indicators of gross motor development. Some examples of functional transitions include floor to stand, squatting, and stand to quadruped. Floor to stand transitions should include a tall kneel to half kneel to stand and should emerge at 11 to 12 months. A functional squatting activity may include picking something up off the floor or playing in a squat position. It is important that your child adopts this movement pattern versus sitting down or kneeling on one leg while participating in these activities. A stand to quadruped transition requires a lot of coordination and motor planning, and your child should demonstrate a reverse floor to stand transition to get into that quadruped position.
Okay, so now we'll discuss the milestones for stairs. So just going through the progression that you should see when your child starts to negotiate stairs. When going up, they're going to start holding on to the railing with a step 2 pattern, meaning they're going to place both feet on each step. So that should emerge around 16 to 24 months. After they master that, the next step would be to continue using that railing support, but switching to a reciprocal pattern where they're alternating one foot on each step. And that should come around 25 months. Once they master that reciprocal pattern, they're going to want to start letting go of that support in order to attempt going up the stairs. But with that decreased support, they're going to regress back to that step 2 pattern, again, with with both feet on each step. And so that should come around 33 months. And then the final step would be combining it all together. So they're not using any upper extremity support, but using that reciprocal pattern with one foot on each step, just that alternating pattern. And that should be mastered by around 3.5 years. And so it's a similar progression for descending stairs, but descending stairs is going to come a little bit later than going up, just because we're using a different set of muscles. We're controlling our way down versus pushing ourselves up, which is just a little bit trickier for kids. So again, you're going to start with the railing support and a step 2 or reciprocal pattern. That should come around 16 to 24 months as well. Then no support with that step 2 pattern is going to come around 25 to 33 months. And then finally, no support with that alternating reciprocal pattern should come around 4 years of age. So things that you might observe your child doing that could potentially indicate physical therapy is if they're placing their hands on the step in front of them when they're going up. If that might just indicate that they don't have that stability to keep their upper body in that upright position, and they're really relying on extra support to keep them stable. Scooting on their bottom when they go down. This could be from that lack of control as they are placing their foot on that next step. Again, that strength and stability piece might be at play there. And then turning their body to go up or down sideways. This is a typical compensation when they're lacking strength in their quad muscles, because they don't have that strength to push up or control themselves down. And so they'll turn themselves to their side so that they are recruiting different muscles and have both hands on the railing. So those are just signs that physical therapy might be able to help with stair negotiation.
Jumping is a motor skill that facilitates the exploration of sensory, vestibular, and the neuromuscular system. Jumping skills also require strength and mobility in the spine, hips, knees, and ankles, the ability to motor plan and coordinate the correct muscles. It also requires your child to perceive the accurate depth or height when jumping off. Jumping in place and jumping forward up to 5 inches should be observed at 25 to 33 months. Height and distance should continue to progress as your child ages to demonstrate continued growth in strength and mobility. Between ages 34 to 42 months, it is expected that a child can jump over a 2-inch obstacle and jump down from at least 24 inches using a 2-footed takeoff and landing. If you are not seeing your child initiate these movements, it may indicate challenges in motor planning and coordination, strength, or mobility.
Then for some balance activities, so the progression of static balance skills, we start with 2-legged stance while reaching overhead. This is something that should be completed by around 25 months. The next skill to look for is being able to maintain their balance on their tiptoes while reaching overhead without moving their feet. They should be able to hold it for about 2 seconds by 34 months. And then tandem stance, which is one foot in front of the other, kind of like you're walking on a tightrope. Maintaining that tandem stance for about 4 seconds should be achieved by 34 to 42 months. And then we move on to single leg balance. So single leg balance has multiple milestones depending on the duration of it. So the expected duration for like 3.5 years old would be 6 seconds. And then for 4.5 years old, 7 seconds. 5 years would be 10 seconds. So it should increase with each year how long they're able to hold that single leg balance. And then once they are able to maintain single leg balance for 10 seconds on their own, the next step would be single leg balance with their eyes closed. which is a more advanced skill that we wouldn't expect to see in children age 6 and older. And then in terms of dynamic balance, which is just maintaining your balance with more complex movements, walking along a line. So it could simulate a balance beam almost, but just a line on the floor should be achieved by 34 months. They should be able to take 3 to 4 steps on that line without stepping off. Walking backwards should be achieved by 34 to 42 months. And then walking on their tiptoes on a line should be achieved by 43 months. So just some functional ways that balance is incorporated into daily life, and why balance is such a big thing that we address is because they're used for a lot of activities that we do day to day, such as putting on our pants. We need single leg balance, kicking a ball, going up and down stairs requires a lot of that single leg stability. And then in terms of dynamic balance, just navigating our environment and obstacles, going up and down curbs, grassy fields, if the kids are playing at a playground, being on that uneven mulch, or just navigating the different playground equipment. Balance is a huge component of being able to participate in those activities.
Another gross motor skill that we take a look at are ball skills. First, I'm going to talk about how you might be able to build interest if your child doesn't independently initiate it. So some options are rolling a ball down a slide, whether they're observing you do it or they're actively participating. Rolling a ball down the stairs or watching a ball fall, observing you throw or bounce a ball, and playing chase or tag with a large exercise ball, like rolling the ball towards them and letting it bounce off of them. You can also take a look at early ball skills, which include throwing and kicking the ball in free space, so no specific target. This should emerge around 16 to 24 months. Underhand and overhand throwing up to 5 to 10 feet forward at 34 and 42 months, and kicking a ball forward at least 7 feet at 34 to 42 months. Ball skill progression may include catching a medium-sized ball from 5 feet away, stopping a soccer ball with your foot from 5 feet away, overhand throwing while stepping the opposite foot forward, and bouncing a ball and catching. And most of these milestones are seen between 43 months and 61 months.
Okay, then coordination and motor planning. These are also skills that we can address. So just to define these terms, coordination is the ability to complete movements smoothly and accurately, whereas motor planning is the ability to plan, conceptualize, and execute a movement. And so these skills both affect all of the gross motor skills that we've previously discussed. And so they can be contributing factors as to why a child might be a little bit behind in those other skills. So for example, things that you can observe that might indicate coordination and motor planning difficulties would be if your child can complete a skill spontaneously, but they have difficulty completing it on command. They might just be lacking some of that planning and conceptualizing that motor planning requires in order to execute that movement, where it might be something more automatic that they can complete when they're not necessarily having to think about how their body is completing that movement. And then, does your child have difficulty sequencing multi-step movements like jumping jacks, reciprocal stepping, or stepping and throwing, like Caitlin just mentioned with ball skills? So again, being able to put those pieces together so their body is moving in that smooth and accurate motion in order to complete those tasks. Does your child have difficulty problem solving when climbing or navigating obstacles? This could be another sign that motor planning is a limiting factor, because they may not know how to plan their movements in order to get around an obstacle or just navigate an unfamiliar space. And then, does your child have difficulty imitating others' movements? So again, just being able to see what somebody else is doing and know how they need to move their body, what muscles they need to recruit in order to do that same motion or stand in that same way as whoever they're imitating. That can be difficult if they don't have the coordination and motor planning skills to do that.
So now that we've talked about some of those specific gross motor skills, we're going to generally talk about some additional benefits of physical therapy, especially within the ASD population. We're going to talk about a journal article that looked at gross motor skills and its relation to social skills. Evidence indicates that gross motor skills and social skills are interrelated, and the literature supports the presence of gross motor abnormalities in ASD. This may include the later achievement of gross motor milestones, atypical gait, fragmented and less accurate reaching skills, poor balance and postural instability, and impaired coordination and object control, or ball skills. Gross motor skills have been found to predict later social and communication skills for infants and school-age children with ASD. Individuals with ASD displayed a statistically significant deficits in every domain of gross motor skills. Within this article, the greatest deficits found were object control or ball skills, acting on moving objects. Difficulties coordinating their own motor behavior with the complex and hard to predict behaviors of social partners. Effective social interaction requires individuals to perceive their social partners' verbal and nonverbal cues and use this to guide and adapt motor behavior and communication. This could be an example of why it is tricky for your child to throw to you or a peer, but they might be a lot more accurate throwing or catching to a target. An example of this is a tricky time mirroring body posture or nodding along with a partner to express recognition, and pausing in response to facial expressions and being able to integrate those into their movement patterns. These issues can specifically contribute to the development of the social problems that characterize ASD.
Okay, so we also have another study that looks at balance performance in autism. So there were two core symptoms of ASD that were evident in postural dynamics. So the presence of repetitive behaviors, meaning the postural asymmetry during two-legged standing, is predictive of the presence of repetitive behaviors, and abnormal social processing. Children with ASD exhibit an increase in postural sway when viewing imaging of happy and sad facial expressions versus neutral facial expressions. And the explanations of this include increased arousal and or dual tasking effects, so maintaining balance while processing the image. The variability of postural sway between both groups increased with the unreliability of sensory information. This suggests that individuals with autism display hyperreactivity to sensory disturbances. And then providing a spatial reference. In the study, it was lightly touching a wall with their fingertips during quiet standing helped to regulate postural orientation, leading to reduced sway. And this effect was stronger in those with ASD versus the controls who did not have ASD. So they benefited more from this tactile input than the control group. And then various studies have examined how motor activities, including running, swimming, horseback riding, cycling, strength, and endurance training, could reduce ASD symptoms, and reported an increase in social and motor competence. So the reduction in aggression and repetitive behaviors was noted, as well as better school performance. And then just some effects of PT or of how PT can impact occupational and speech therapy. So in terms of occupational therapy, the stability and postural endurance that we can work on in OT can be helpful with table work and fine motor skills. Once they're able to support themselves in a sitting position with that upright posture, and if they're able to sit at that table for a longer time, they're going to be able to complete more tasks without the fatigue of their core musculature. Postural endurance can also be helpful for sensory regulation. When kids do get fatigued, there can be an increase in dysregulation. And so by increasing their postural endurance, it can help to maintain their sensory regulation for longer periods of time as well. And then proprioception, which is another way of talking about body awareness, knowing where your body is in space. That is something that PTs can help with, that can also affect regulation and fine motor skills. In terms of speech therapy, again, that endurance piece is going to be helpful for them to be able to engage with peers, teachers, family, just anyone that they're interacting with. Having that endurance can help them engage in communication with others. And then postural stability can promote proper alignment for speech production and swallowing, which can help in feeding therapy as well. And then as we were talking about that motor planning piece, knowing how we need to plan and conceptualize our movements, that can overlap with the motor planning skills that are needed for speech production.
Repeated exposure to gross motor skills in a wide variety of environments and situations can help to generalize your child's skills. Getting involved in extracurriculars such as CSTA's social groups, swimming, and Taekwondo can be a great way for your child to build confidence and have fun while working on their gross motor and social skills. It's important to remember that modeling without expectations is a great place to start when trying something new. And tomorrow or the next day, we will be sending out a document listing resources and specific activities to try at home. And over the next two slides, we've included a summary of observations you may have while your child is playing, and these can be an indication for PT.